All right. Did you get this working?
Yes.
Or it's the green?
Hit the green one. Yep. You got your microphone there? Okay. All right. Okay, guys. Welcome to our education today. And those that are online, thanks for being online. Appreciate you coming in. Those online, sorry about lunch. We'll have to, catch up later some another time. But appreciate our cafeteria for helping us out today with this. We have Sandy, South Jordan, and Draper here today representing. So appreciate you guys being here. And we have Dr. Mary Tipton here. Tipton?
Mm-hmm.
Tipton? No M in there.
Right. People always try to add a little tip or nips, Tipton.
Yeah. I read her bio, but she would have started at age 4, according to her bio, with all the education and the training and the stuff that she's done. So she's been around for quite some time, working with pediatrics and internal medicine. You can treat all ages, from what I understand. Mm-hmm. So you're currently working with Blossom Health, direct primary care, and you're based out of that other side over there, that other agency.
The west side.
But she is affiliated here with Lone Peak Hospital as well. So we appreciate you being here and presenting to us today on pediatrics. So we'll turn the time over to you.
Awesome. Great. Thanks so much for coming, you guys. So a couple different cities. And we have a token lady back there. Is that right? Good job. I was like, are they all men? In EMS. You identify as a female today? That's good. Okay. So does anyone know what a direct primary care practice is, or direct primary care? So that'll be fun. I can tell you at the end. It's a different model of payment, but I do primary care of all ages, and I am board certified for internal medicine and pediatrics. Internal medicine is a specialist for adults. Pediatrics, you probably know, a specialist for pediatrics. Who's scared of children, or specifically infants and toddlers that can't breathe well? A little bit sphincter pucker on that one? Okay, good. So then you're in the right place, because we could talk about that. And I clearly remember this a long time ago, like you said, but when I was in medical school at the U, and I was in the pediatric clinic on the first floor in the old hospital, and I saw my first bronchiolitis patient, and with that chest sucking in super hard, and you could hear them coughing from the room, and they're just kind of like, and you walk in and the chest, and I was like, oh dear God. So yeah, I remember that, but it's like after experience and a little more evaluation, you could become competent. So we'll just talk about what bronchiolitis is first. Obviously, it's just a respiratory infection. It's often caused by RSV, but it's not always caused by RSV. It could be any number of different viruses, which we'll discuss. The key being a lower respiratory tract infection. That's why I highlighted that word lower, because it's different than upper respiratory tract infection, and that's what makes it a problem, especially in the younger children. So bronchiolitis, which is inflammation of the bronchioles, is more prevalent in children under 2. So it can peak usually between 3 and 6 months of age, but it can also be basically life-threatening or deadly for a neonate or an infant. And you can see it especially in kids who have like asthma or something a little bit up into the 2 to 3-year-old range. But basically it's like an infant type of illness, right? Usually fall and winter, there is kind of a diurnal variation. We sometimes have different peaks of the respiratory season, but essentially by November, it's usually getting going. Sometimes it's a little later, and it's basically done by April, May, even though there's sporadic cases. But you can get bronchiolitis any time of the year, because those viruses are actually, there's more than just RSV. So that could be a summer bronchiolitis, and you're like, this is so weird, but there it is, Okay. So as I mentioned, lots of different viruses cause it. All these are some of the bad actors here in the lineup. You've all heard of coronavirus. In the right patient, that can definitely cause a bronchiolitis type picture, even though it can also cause other type of cold, or, the dreaded COVID. Influenza, parainfluenza. Have you ever heard of human metapneumovirus? Because that can be a bad actor and also has like a little bump at certain times of the year, causes bronchiolitis and other respiratory illnesses. And no, I don't know if they're really green or blue, or like I just picked whatever. They're just different viruses. And rhinovirus has eyes, so I don't know. So these are some of the causes, and RSV is on there, but it's not the only one. So that offending virus infects the bronchioles. That's like your airway here showing, it should be like a thin tube, you know, like a nice airway pipe, except now it's thickened with this mucous membrane there, and then this snot is basically plugged up in there. And that mucus production obviously leads to a narrowing of the airway. And if you've ever tried to breathe through a straw or any sort of narrow thing, it doesn't work very well. And then when that straw is also full of gunk, they're just having air trapping, difficulty breathing, and basically obstruction of their lower airways, which is a problem. Okay. So what you see usually is when you evaluate them, it's not day one of their illness, generally speaking, if it's bronchiolitis, right? Because day 1, 2, 3 is like a cold, kind of just, you know, runny nose. Maybe they wouldn't bring them in to be seen for it or think that much of it. It's after the runny nose, cough either gets better or then gets worse. And if it's bronchiolitis, it's getting worse, progressing to a lower respiratory infection. That's wheezing, tachypnea, that's fast breathing, respiratory distress. So when you're looking at a patient thinking, I wonder if they have bronchiolitis, you have got to get them naked, right? You have to look at that chest wall. That's your best key there for figuring out if there's lower respiratory infection. They can't be in a car seat. They can't be in their like jammies or whatever for a real evaluation of their work of breathing, as you probably know, and then listening for crackles and things. So there's some things we'll go over in some detail about the physical exam findings of bronchiolitis that are different than a common cold. But it does start as a common cold. And then, depending on the age, depending on these kiddos, I mean, if they're really sickly, if they have asthma, if they have a genetic disease or a developmental disorder, they have weak lungs, they're going to maybe have bronchiolitis later or more severely than another healthy kid if they're premature, right? Like the age, the comorbidities always plays a role in all these diagnoses when you, that's why you guys ask people, do you have a past medical history? What medications do you take? I worked at Copperview Medical Center for 18 years, so I called EMS many times, and I was always very grateful for y'all to just scoop them out of there and then help you guys get the history. And so I have a lot of respect for you guys and gals. But anyway, as I mentioned, it starts with URI symptoms for a couple days, but then it's like day 3, 4, 5 where it kind of peaks, and then that's where, you know, we might have a problem and they might be calling 911 or coming to the ER something often. But this is a key, and whose kids have had RSV in here? Or a bronchiolitis? Yeah. That cough just goes on and on and on. Like even when they're fine and they're running around and you're just at church and everything's cool, and then they're just like hacking and everyone's like, dear God, what is that? And you're just, it's fine. It's like better than it was. It's like totally fine. So yeah, average cough is at least 2 weeks and goes even, so the 90th percentile, what that means is like, if you had 100 people with bronchiolitis kiddos, then 90 of them would be done with their cough in 21 days, but 10 of them would still have a cough even after 21 days, even if they're like recovering normally from bronchiolitis. So it's a very long cough. So that's something I would tell people about. And maybe you guys don't do as much anticipatory guidance, but for your own sake, just know it's like a hell of a thing. Kids are so pissed off. So we're gonna do a couple different studies, 3 different case studies, because we like interaction, right? You gotta stay awake. I mean, you have your Red Bull, so that's good. But we're gonna start with case number 1. Which is a 9-month-old presents with just, they say it's a 2-day history of runny nose, low-grade fever, and a barky cough. And you notice when you're listening to him that he has inspiratory stridor. Someone needs to tell us what that is. Gentleman here. Yes, the upper airway is definitely true. I wouldn't say hoarse as much as just a noise. Like it's like normally when you breathe in or out there, you don't hear a noise coming from here, right? So it's just a noise, which could be like a hoarseness or a type of noise. And inspiratory means it's on breathing in as opposed to breathing out. So yeah, so it's a noise when you're breathing in. So it's a like that. So as they breathe in, so inspiratory stridor, and then he does have a hoarse voice, which is more of like that gravelly thing when they're actually talking, and they're expiratory, then you'd see the hoarseness, I think. So it's inspiratory stridor, which is normally inspiration is silent. Basically, it should be silent. Okay, so thoughts about what this kiddo might have? Could be. Croup. Why wouldn't it be bronchiolitis though?
Upper.
Because of the noise?
Noise, and you said that bronchiolitis is lower. airway.
That is very true, yeah. So it's important to differentiate. This would be kind of your classic presentation of croup. So croup is also caused by viruses, the same viruses that cause bronchiolitis. Saying epiglottitis is smart because it's saying like something upper, like it's something going on in the upper airway, which could be your epiglottis, could be your vocal cords, which is croup, inflammation of that. But basically you have that inspiratory stridor. So then you're hearing them breathe, like, like that inspiratory noise. And then the barky cough, which is usually that harsh, like, or what, I'm not going to do it, like that, yeah. And hoarseness and often para-influenza. Anyway, often it's the middle of the night, right? Like they went to bed fine as tiny runny nose, they wake up severe pain, and they're like really in distress, and their parents freak out. So, yeah, which is understandable. And then they call EMS or something. So difference between bronchiolitis. Unlike croup, it has lower respiratory symptoms, which would be maybe the wheezing, the crackles, the adventitious sounds like this gentleman mentioned. And then usually it's like, it's a really wet cough. I mean, there's a lot of crud in there and you're just hearing all this like rattling and noises. And like, it's really one of those where you could put your ear to it. Or have you slept with your kid that has bronchiolitis? I mean, every single breath, you're just like, there's so much crap in there. So that's different than croup, which is more of like a harsh sound. Okay, good job. Case number 2. So this 12-month-old female is brought in. She suddenly had this onset of wheezing and difficulty breathing. And then there's some coughing and stuff. And you ask the parents a little bit like, so when did this start? That's when they say, it's sudden. It's just like at dinner time and they were eating. And then, well, what were they doing before that? Well, they were playing with these little, like a marble game or something. So any thoughts on what this could be?
Obstruction, airway obstruction, upper.
Airway obstruction, yep. Aspirating something, yeah, any sort of something, because the keys being the sudden nature, right?
What?
So sudden onset of symptoms, that would not be bronchiolitis. Bronchiolitis is like, well, they've been sick for a little while, or like everyone has a runny nose in the house, and then suddenly this baby started struggling or something. There's always, that's a pearl, I can tell you, like almost every single time they're like, well, yeah, is there anyone else sick at home? You ask them, and they say, well, yeah, the brother had this thing, and it was like no big deal. But then this baby is like having big trouble, and you're like, okay, same virus probably. Now it's bronchiolitis in the baby. It was just like a mild cold in the other. But sometimes with choking, or an aspiration of a foreign body, it predominantly goes down the right or left bronchi.
Right.
You're so smart. Right main stem bronchus obstruction, carrot stick, hot dog, whatever, right? And they will, sometimes if they're chronic, I've seen chronic foreign body aspiration that was undiagnosed for a long time, but they could be longer time, but hopefully you diagnose relatively soon, and then you might have asymmetric, right, exam, because maybe they have less breath sounds on one side. But it's that sudden onset that's different. Because bronchiolitis is gradual, has the bilateral sounds, no history of choking, wasn't while they were eating, suddenly this happened, it was like gradual or subacute. Good job. So case number 3, we have a 6-month-old. This kiddo is just peeved. As you can see, he has 4 days of nasal congestion, mild cough, low-grade fever. And that was okay, but now presenting with some breathing that's harder work, or increased work of breathing and some wheezing.
You want to expose his chest and watch him breathe.
That would be a good assessment to figure out. Yeah, because you're like trying to figure out, I mean, I know they have a cold, right? Some sort, some infection. Okay, so definitely they have an upper respiratory infection. That's kind of just by the symptoms. It's been a few days. They've got the runny nose, cough, rhinorrhea. But then you're like, but then when that wheezing thing came on, did that kind of make your brain think like, oh, maybe something else is going now? It's like progressed into something else. And that's kind of the key with bronchiolitis. It's a progression of the illness. So there's many a person who has or kiddo or adult even, that has the same virus infection, like that whole list of bad actors I showed you, they'll have it. And they are better in 3 to 5 days, and that it never goes below here, right? It's all upper respiratory. But then there's a subset of people based on like age, comorbidities, problems, where they have that progression to the lower, and then you have bronchiolitis. So it really can, I mean, it is a URI, but it also could progress to bronchiolitis. Does that make sense? Same infection, same virus. It's just whether it goes down there and progresses, or it kind of like they fight it off and then they're done. It never really hits the lungs. But if it did go then to the lower respiratory symptom, then you're calling it bronchiolitis. And then you'd have the wheezing, increased work of breathing, maybe low oxygen. And then usually parents will identify that it's an issue at that point. Although people have a lot of fear about whether they'll be able to identify their child with respiratory distress, I have been told that by all moms for so long, but when it really happens, we're all pretty good at at seeing, at least having some inkling like they're struggling. Not always. I mean, sometimes they bring them in and parents like, I don't know, I've been sick for a little while, and I glance over and I'm like, oh my gosh, like, because they're like tripoding and they have a, and I'm like, yeah, we have a problem. And they're like, oh, I didn't think it was that bad. But most of the time people do kind of sense like they're struggling. So I just wanted to go over one more time this difference between upper respiratory symptoms and lower respiratory symptoms. So, I mean, I belabor it, but we've got the common cold symptoms on one side, and then the lower is where you progress to like the faster breathing, fast for age, right? Because the fast breathing rate in an infant might be totally different than an adult. Probably got to have all that memorized, and you have your vital sign charts and things. And same thing with heart rate rates, but wildly different. You'll usually have quite a bit of tachycardia as well. If you've evaluated kiddos with respiratory distress, I mean, they are like 140, 150. And their heart's just going, especially if they have a fever and then they're struggling to breathe. Yeah, really fast heart rate, really fast breathing. Even if they're kind of smiling and like playful about it, then, but you're like, they're teetering on the edge, right? Wheezing, crackles, increased work of breathing, which we'll talk a little bit more about, and then potentially low oxygen. Do you all struggle getting good oxygen readings in the field on infants, or you have developed techniques to do it? What are your tips? I want to know, because it's one of the hardest things for me to teach, like, staff how to do accurate pulse ox.
Take their socks off. Let their little foot.
Definitely take their socks off. The little probe requires light to work.
Use the disposable one and wrap it around the toe, and then put Coban on it because.
So you use a toe?
We also have different ways to get probes. We have an ear probe.
Do you have an ear?
Yeah.
I like foot the best if you can access it. I totally agree. Or even like on the infants, I'll use the whole foot, right? Like, or the side of the foot, if it's just depending on size. And then bigger kid toe works, but toe is like impossible with a neonate or a newborn. I don't have any experience with ear probes, so I don't really know anything about that because we don't have them, but I know what they are. I've seen them in the hospital. I've never used it, but that can be handy, I guess. I don't know how accurate they are in infants.
At least for us, they're not super accurate.
Yeah, I just think that would make me nervous. But I bet they're fine for adults and some other things. And then hand also, and finger is really tricky. I mean, they're just like this, or they're like on there. And of course, when they move, that's like the hard thing, right? Because you just get it, and then they're just kicking and moving, and you're trying to get them to forget about it. So I usually takes a while for me to get like a good waveform, right? Because you see it reading, and then so hand or foot, and then distract them, obviously, or try to cover it up with the sock after you put the thing on so they can't see it. Because like when it's on there, they're just like, they're just freaking out about it. Or the hand, and you could do the similar like to the foot. So like the side of the hand. But anyway, getting an accurate pulse ox is like so key. I'm sure you all have, experience where someone says, oh, I did this thing and it was whatever. And you're like looking at them and they're not moving. You're like, let me just check that. And it's like not 75 or whatever. Yeah, because, they had their little night owl sock and they're like, it's whatever. You're like, okay. We'll let the experts take over. So you're going to assess a baby. We're going to talk a little bit about your assessment. So I don't know what your typical calls are. I guess you get called for respiratory distress in a home. Is that like typical in the middle of the night?
Or clinics, yeah.
Or clinics, okay, where they've always already been evaluated, but you're still going to do your initial assessment, ABCs. You guys know that better than me. And then your most important assessment, right? Because like after vital signs is their assessment of their work of breathing. And there's nothing to substitute just experience for that and practicing and looking at babies. And it's subtle, a little bit subtle, I can tell you from 20 plus years of experience. Like, because at first it's overwhelming, but then you start noticing. And if you really watch like that nasal flaring, for example, if you look for it, you're like, oh, they are nasal flaring, but you really have to like look for that. And then you have to look for the other spots and like assess one by one. Obviously, if they're blue or that perioral kind of cyanosis, other things, like if a baby's screaming and crying is kind of a good sign, but like if they're not, it's almost worse, right? And then there's a stranger in there and they're just too tired. Like they just kind of look at you like, whatever. And you're like,
Like the pulse socks?
yeah, those could be concerning, right? Because they just already maybe like tired out. Anyway, so have you ever heard of a severity or a bronchiolitis score? A severity score? Really? Oh, I can teach you something today. Okay. So the bronchiolitis score, I just did an example one from one of our local hospitals that they use, but there are several. They're very similar. It's a way to judge in a numerical fashion how significant the severity of the bronchiolitis is. And it's used for assessment and then reassessment after like an intervention of some sort. So first is respiratory rate. It's different for the age, right? So then if they're less than 1, it's a problem. If it's more than 1 per second, right? If they're just panting like 1 per second and they're less than 1, that's a higher score. But if they're older, then the number's different. That's all the first 2 things are, is just respiratory rate judged by age. And then wheezing, also non-trivial. There's crying, there's clothes everywhere. The parents are panicking, whatever. Other kids are screaming, and you're trying to listen for these subtle sounds. It's not easy, but essentially, if you could at least identify, like, is there sound when they breathe in? Is there sound when they breathe out? Or both, or none? And that's kind of your score for that. And you would try a couple different lung fields, ideally, right? Retractions. So we're going to go over a little bit about the location and type of retractions, but you're going to be looking, tell me one place where there could be retractions, because there's going to be none, 1 or 2, or whatever. Like, we have to come up with at least 4 locations, I guess, if the score goes up to 3+, right? So what's one location for a retraction that an infant could have?
Intercostal.
You said intercostal. So what does that mean?
Between the rib, chest wall.
Mm-hmm. So it could be anywhere in the rib, chest wall, right? And you're just seeing that like sucking in, or like the definition of their rib cage, because normally when they're breathing, you really couldn't look at every rib, but yeah. Perfect.
Clavicle, throat, and clavicle.
So supraclavicular, or which is here, or above the clavicle, right? Could be either or both or whatever. Yes, because again, normally, I mean, you have to see their neck. That's also a challenge in the no neck baby. But you kind of have to sit them a little different. But if you can see the neck, it's not too hard to spot if you can get it in the right spot, right? And it will just be like sucking in right there when they breathe. Or even the I mean, that's really rare for an infant to have, although adults will tend to have a clavicular because they're using those accessory muscles. I don't know why, but I don't think babies can move their clavicles very well. I don't really know. But I usually just see here. I'm trying to think, like, how are they getting their clavicle with no neck? But I get the point. So supraclavicular or substernum. And then, I said wrong. I said one of them.
Substernum.
Okay, where's that one? Yeah, just below the chest, like just that caving in, because they have a really cartilaginous soft chest, right? So it can go easily 1/3 to 1/2 of their chest circumference suck in with every breath.
Would you consider nose flaring as part of the retractions?
Yes, I think so, because it's just another way that they're trying to increase airflow or to like suck it open. And so nasal flaring could totally count. The other one would be belly breathing, kind of that paradoxical kind of movement of the chest and the belly. Yeah, so any of those, and this isn't exact, but obviously if you're like there, you're like, okay, that's a high bronchiolitis, very score. And then you add it up. And then basically if it's 5 or greater, they should consider ER. This is like things I review with parents, although I don't have them assess this necessarily. I just kind of explain to them, because when we send them to the respiratory outpatient clinic, who's familiar with that part? You know about okay, we'll talk about that in training. Then that's kind of what the respiratory therapists there do, is they do an assessment of this. They do an intervention, which could be suction, a neb, maybe something like that, and then they redo it, right? And I didn't know if you guys would do this necessarily, but you could do this at the best. You could kind of do a quick assessment and then maybe help them suck out the nose, because you're like, well, there's like 0 nasal airway, and you might help them in the house doing a little sections and then like reassess if that helps or something, or you just transporting. I'm not sure, but that would be the type of thing that a responder could do, right, to improve the baby. But it's all based on their severity score. Or if you add it all up and it's like 1 or 2, you're just like, yeah, you're fine. Just go back to bed. Okay, so severity score helps us. I just have a video here that hopefully will play. So look at this baby for the different retraction locations, and then also the more ominous cyanosis. Okay, just kidding. That did not work. Okay, I think I have to click this way. Let's see if that works. So fast breathing. Oh, we didn't talk about grunting yet. You see the suprasternal, supraclavicular there. I don't know if you can see intercostal, but it would be right there. And then, of course, if the blue lips are perioral pallors, no bueno. Anyone want to see that one again? Or are you good? Let's do one more time, just for fun, because it's only 20 seconds. So, yeah, so you see why you have to have, of course, the chest exposed. to see those. You have to get them naked, like those damn onesies. I mean, you just have to and all the way up because you cannot see.
And mom and dad are like, oh, they're freezing, don't.
Yeah, and you're like, airway is number one, okay? Breathing, number two. No, yeah. So important to get them naked. Okay, good job. Oh, I don't know. I'm good. Okay, so I picked this picture last night, and then I was like, that's so dumb. I can't have that picture, but then I just kept it because it's freaking hilarious. Have you ever seen a baby look that pleasant when you're suctioning them? Like, ever? Oh my gosh. First of all, they are pissed to the nth degree because they have bronchiolitis. And then if you approach their airway with saline or actual real suction, you have to have like 2 people to hold them down. It is held. It is rough. Yeah, they never call, please just punch like this gal. But anyway, so one of the things I do as a pediatrician is I teach people how to suction their baby because it is so magical when you can do it, but it's very hard for most parents to do because they're so worried about the distress of their child. I mean, it's basically waterboarding and like in restraints. But when you do it right, it works. So I teach them to hold the arms above the head. By the way, babies have like they're very weak. If they're down here, they can do all sorts of crazy things. But if their arms are up, they really can't like fight it as much. So I pin the arms down like that. And then I use that finger to plug one of the sides of their nose. And then I just put in a ton of nasal saline. When I say a ton, it's more than you would think. Drops, not so good. Milliliters, like you're waterboarding them, kind of. It is like that. So when it's like going in their nose and they're spluttering and piss off and it's down the back of their throat and running down in, and then you start sucking it out because you have to lubricate that thick stuff. And you can suck it out. Those nose Fritas are genius. That's a home suction device. You guys have fancier suction devices. The bulbs are meh. Actually, that is a nose Frita. But bulbs are not my favorite. So definitely the other devices are the ones they have. So the key is tons and tons and tons of saline and 1 nostril at a time so you don't actually kill them. Because you want your arm like this. And then you have all that water going. And the reason for blocking one side is to get more suction. Because like if you suck through one side, it's just basically like coming out the other. So you really want to, like get suction. Because you're at home. You don't have a machine. If you have a suction machine, you're fine. But I'm talking about things people do at home. So they block that airway. And then I tell them, like, suck that out really good. Irrigate a couple more times. Suck that out. Then do the other side. Give them a break for a second. Make sure their color is good. I mean, if they get a little peri or cyanotic when they're holding their breath because they're angry, fine, as long as they can recover in between your little cycle. If they get red and purple face, that's normal, but, then do the other side. Does that kind of make sense? So suction, 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 suction. And you guys could coach parents a little bit. Oh, I could suck out your baby, or I'll help you, or let me see how you're doing. And then, like, it could literally avoid the whole trip to the ER. A lot of times I'll just tell you about. Okay, but if they're still hypoxic, if that's not working, obviously they might need oxygen. When they get into the hospital, a lot of times they're dehydrated because they're just been so tired of breathing so fast for so long. They haven't eaten and they need maybe some high flow nasal cannula or positive pressure support, which can you give that in the field to a baby? High flow or actual, or just mass? Like nasal CPAP? Cool. That would help a lot. Okay. And if they persistently hypoxic, definitely apneic. That's an ominous and later sign, especially with a baby less than 1 month. They will just decide, oh, I'm having a lot of work of breathing. I'll probably just stop. And that's not good. So yeah, they'll just have pauses that are longer than they should, which is like longer than 5-10 seconds. That's a bad sign. And then they need to be monitored, right? Or really severe respiratory distress. So those would be the reasons you're transporting a baby. Obviously, they can get so severely dehydrated that they could have worse illness or lose consciousness or have kidney failure, that kind of thing. Apnea, I talked about respiratory failure. And it's very common to have ear infections with bronchiolitis. It's just really thick snot, and the snot is communicating between the nose and the ears, all there together, all just swimming around, and it gets in that middle ear. Ear infections. And pneumonia. But those would be like a secondary infection, right? So not like they started with ear infection, then got bronchiolitis. They started with a URI, then they got bronchiolitis, then they get the ear infection. Applications of that. I have a few topics. I don't want to bore you, but we can go rapid fire through some of these topics briefly if you're still interested in hearing a few pearls or if you have questions about them. Okay, awesome. Have you heard about or tried to give a nebulizer treatment to a kiddo with bronchiolitis? Probably.
Yes.
Probably. I mean, you just don't know. Like sometimes you try it or you think it's been tested a lot and studied actually. And albuterol is not helpful in bronchiolitis at all, really, in general. But the problem is you don't always know. Like, is it bronchiolitis or do they also have asthma? So what we're teaching and telling, like basically guidelines these days are that if you're pretty sure it's bronchiolitis, there's not a strong history, a personal history of asthma or reactive airway disease of some sort, they don't already have an inhaler. I mean, you're just not going to get any benefit. And they've tested this with albuterol. So you don't need to try it. If you are so inclined to try it because of some reason, or you just think, or you're not sure, it's not going to hurt anything. But it probably won't help, except in a select group of people. So that's kind of the thing. So it's always, I mean, what are you going to hurt someone with an albuterol treatment? Like it's fine, it's no big deal. But in general, you shouldn't be like, oh, bronchiolitis, let's give them albuterol. No, it's not going to do nothing really. So that's pointless. But in most cases, but you just don't know all the time. And if you're not sure, and you just give it. That's okay too. And then reevaluate and see if it helped.
Are you guys recommending with bronchiolitis nebulized epi?
No, that has also been studied and hasn't been shown to be helpful for bronchiolitis. Yeah,
No.
It helps with upper airway, croup, but not lower.
How about just nebulized saline, just trying
I
to,
mean, humidification in general seems to always be relatively helpful for mobilizing secretions, but that's not too different than the waterboarding technique I discussed, which is euphemistic for nasal suction. So maybe, yeah, I mean, I've done that with my own kids, like just humidified air, right? Because you're like, let's loosen up the secretions, then they can cough it out. Maybe. So also harmless, I would say. Okay, so people are often asking, well, did you get tested? Did you get tested for RSV? Over my career, I've used RSV tests less and less and less because it doesn't change your management most of the time. There are exceptions for sure. I don't refuse to do RSV testing. I do it sometimes with daycare settings. I do it sometimes with certain kids that are really, well, it matters, like for some reason that if it's RSV or not, maybe the length of the course, sometimes you're just trying to predict, like, is this going to be one of those 3 week? We kind of need to know, and let's just see. Sometimes I do it in neonates when we're not sure, like we need a reason that they're so sick. And if we know we have that RSV reason, we can stop doing the spinal tap and the other things. So there's some situations in which you do it for sure, but it's definitely not required. Like you can probably imagine how it doesn't matter if it's coronavirus or RSV or parainfluenza, you're pretty much going to do your suction, all that stuff the same. So if it's not required, but it can be helpful. I think it's like most things should be a discussion with your doctor, case by case. Parents always want to know what medications they can give for their kid with bronchiolitis. None, basically, almost none. Yeah, Tylenol is always okay. Yeah, nasal suction is your main key, and then non-prescription things, basically because over-the-counter medications for cold are not recommended in children age 0 to 6. In general, they're just, I tell people, like, you're just spending money for nothing. I mean, the honey thing, I don't know. The honey is maybe the one thing that has been proven a little bit, and of course they just marketed the hell out of that, and then somebody making money right across the street here with a crazy idea. Lots of money. But you don't need specific medication generally. Unless there's fever, discomfort, you can always give Tylenol, you can always give ibuprofen if they're over 6 months old. And then sometimes Benadryl is helpful just because there's so much secretion, like dries them up a little bit, but like decongestants, no. Cough suppressants, no. Other homeopathic remedies that I know of, not so much. So, questions about over-the-counter medications or any other, or even prescription medications for?
So there's not any prescription?
Yeah, not like an antiviral or something. Yeah, no, we do have some vaccinations now, but not really treatment. So you're just supportive care. Yeah, so you're treating the other infections, you're treating the asthma if there is some, you're treating their other illnesses. Oh, I didn't mean to go forward. Sorry, back. Okay, asthmatics tend to have a worse time. Have you heard that RSV causes asthma? It's a common concern that people will say, like patients say to me, well, they were fine until they got RSV and then they have asthma now or something. It's usually they really had that predisposition for asthma and then they presented with RSV. Almost every child, but basically every child gets RSV. People just don't know they have it because some are so mild, they never get tested. It's the ones that present that are more severe, which are often the ones who have this like atopy, or I think they're going to go on to have asthma. So we usually just think it doesn't cause asthma, but it's worse in people who have that tendency to have asthma. And that's why like later they have asthma because they always had it, but then RSV made them really sick. And then they got evaluated versus the kiddo that just had a cold. And you're like, well, you just have a cold. They're better and you never test. You see what I'm saying? So most people are like, did you have RSV? Did you have RSV? But like probably everyone did. They just didn't all know they had RSV. So it's just worse in asthmatics, but it really doesn't cause asthma. And it is harder to get over and just struggle. And sometimes they can benefit a little bit from that albuterol. And that's where we just get like, let's just try it and see sometimes. But. Okay. Always more serious in neonates. Everything from age 0 to 28-day infant, right, should give you pause because they can hide how sick they are. They don't have that strong respiratory drive. They have very small airways for their body, so they just cannot compensate with swelling of airway or deterioration of their ability to breathe at all can be life-threatening. Does that make sense? So they should be evaluated, and any infant with RSV needs like really close monitoring. Or neonate, I should say, not infant, but like, so neonate's like 0 to like 1 month old, less than 1 month old. Can you get RSV more than once? Anybody know?
Yeah, it's different
You
virus.
definitely can. Yeah. Yes. In my next slide, I'll show you my now 14-year-old who got it 4 winters in a row. Just to trouble me. It's an occupational hazard. There's vaccinations for RSV both for pregnant women and also for infants. There's 2 vaccinations, it's not really a vaccination. There's a true vaccination for mothers that helps them not pass RSV onto their baby or like when they're in that first year of life. But then there's a passive immunization. That's the an immune globulin that's like a 1-shot we kind of call vaccine. And there's 2, I did the studies for both of them in my practice at Copperview, and one is on the market and the other one's coming soon. But so it's a 1-time shot. It's actually not active vaccination means it's like a piece of the virus, and then your body builds an immunity to RSV. You know, most of our vaccines are active immunization. Your immune system has to do the work after it gets exposed to that thing. But passive immunization is where it's just giving you like a long-acting immunoglobulin that's specific to RSV. That's why the passive immunization for infants that they have now is like a 1-time shot that lasts like 5 months, so the whole season, and it's just given their first winter. I don't know if you knew about that. It's going to be a little more, I think, available this winter to give to infants. They're definitely trying to give it to high-risk infants. So if you're out and about, the parents might say like, but she got immunized against RSV or something, you know, like if you're a transplanting baby, oh, they shouldn't get RSV because they got immunized. It seems very effective. So in the studies that I participated in, but, you know, we'll see how it goes in the real world.
What's that called?
Well, you had to ask.
Strike that.
There's always a one guy.
I was trying to think about it when you were saying that, and they're just these ridiculous made-up names, and it starts with a B. Okay, it's going to come to me. I'll tell you at the end. Yeah. There's 2 brand names, and then there's Merck, and since I did like both studies, and we call them other names. I'm like, I should have put that on there. Okay, and RSV vaccines for older people. Did you know that? Yeah, it's all changed a lot recently. So 50, 60 and up can get immunized against RSV too, but we're very rarely testing RSV in older women.
So
Questions about any of those things?
I know this is pediatrics, but there's a few of us in this room that are geriatrics.
Yeah. Well, I'm internal medicine, so I know about all that too.
Just a real quick, what are the signs and symptoms for adults with RSV? Similar?
No, it is different because the airways are different. Like we have this longer neck, we have bigger airways for our body ratios. But I mean, it's respiratory symptoms, obviously, but it's just not as much of the like trapping and well, I guess you'd still have wheezing and stuff, and you just have like fever. Basically, adults that get hospitalized with some respiratory illness, apparently like a large proportion of them have RSV. So they're having all the typical like low oxygen, fast breathing. I guess in a lot of ways it's the same. It's just so different, right? In adults, how they look and how they present. But if you list the symptoms out, it's like, okay, yeah, they're all the same. That's probably true, yeah.
Okay.
Yeah, could have fever, just like that. Okay, hold on. I'm going to give you the name for the thing. And then, so this is my family, which all 4 4 of my children had RSV, and not the one misbehaving over there on the right. She only had it once, but my daughter with the dark hair had it 4 times. And she also has asthma. So I think that's what, like, she would just get, every year she would get exposed to it, and it was just a whole like thing for a month or whatever that she was sick with it. Okay. Nirsevimab. Okay. I'm still working on the actual names. Anyway, it's a monoclonal antibody. It's long acting, and then we'll figure out what the name is here. Name brand. That's what we have to search. Now, is any other questions or comments before I tell you a little bit about direct primary care? Yes.
What about doing other epotropium
For infants?
Yeah.
Or
for just if they've got bronchiolitis?
I don't know that I don't think it's been helpful. It's been tried.
Okay.
Yeah. I bet it would help more in adults because I do that a lot. Like you guys use like a Duonab, right? Or like a combination, and it seems to really help when they're just all this kind of like mobilized things. So, but in pediatrics, no. I haven't seen that as an option, so. Oh my gosh. Beyfortus. I knew it was a B. That's one of them. That's Beyfortus. That's the one that's out. And then Brisvia or whatever. Oh my gosh, these are so hard to remember. The other one's not hit the market yet. So Beyfortus is the one that we have. And I think Lone Peak has it here in the nursery. They give it to high-risk babies. So yeah, I left the insurance-based model after 18 years in Copperview Medical Center because I feel it's irreparably broken. I'm doing something called direct primary care. So I just wanted to tell you because the more people that I can educate about it, the more people will know about it. The things that I think are irreparably broken about our healthcare system are many, but the ones that affected me the most being a business owner and trying to do my best for patients in primary care is that the only incentive really within the system is higher volume of patients, right? Because it's all about money. And then in order to make money, you have to see patients really fast. And if you're seeing them really fast, you're not doing as good of a job. And also, there's a lot of replacement of, and because you're trying to just push people through more and you don't really have enough doctors, then you get doctor replacements. So then clinics and a lot of places are, instead of doctors, you're seeing nurse practitioners, PAs, which are great, valuable members of the team, but there's kind of a certain ratio of expertise that I think should be in all areas of healthcare, including a physician at the lead because of the difference in education. So some of those were at play. And then just, I just knew every day I couldn't serve my patients well when I had 5,000 patients on my panel and 10-minute appointments, and it's basically killing me. And a lot of other primary care docs, of which I, have lots of love for and empathy, right? Because I lived through that. So direct primary care is a model in which I am employed directly by the patient. So the only people telling me what to do is the patient because they're paying me a monthly fee. It's a monthly membership option, a monthly membership fee for that covers all their health care. So I have one employee instead of like 20 to 1 at what I had at Copperview or any other clinic where you have to have billing staff and fight for every little payment and do whatever the insurance company says, and essentially the government's telling you because the government pays entities cover, tons of healthcare dollars and Medicare, and TRICARE and all that. So I just was like, I am the doctor here. I know what's better for my patients, and I'm so frustrated being told what to do. And then at the end of it all, really like getting so low pay for so much work. And even that would be okay because I am a hard worker, but providing a low level of care to patients is unacceptable for me. So in direct primary care, I have much less patient population, and then I'm spending 30 to 60 minutes with patients because, again, I have lower overhead, lower volume. I don't have to meet certain metrics and stuff. And then I'm still providing the same care, though, but like more coordination of care, more attention, so they actually can see me when they're sick. Urgent care, most direct primary care practices, and there's a few in the area that I'm just kind of paving the way here on the west side. For pediatrics and trauma medicine, it's acute care, chronic care. They can text, call, email. Like I got several messages while I was here from patients about different things. I'm going to respond by the end of the day. They can get same day access, next week access. I do a lot of care coordination. I do the same work, but just A+ work instead of C+. And that was not okay with me to do that. So yeah, it's a different model. It's very good for people who are uninsured or functionally uninsured, as many people are, meaning they have a very high deductible, and their only options within this really confusing healthcare system is to just get some care and then get a surprise bill later that's like really, really expensive. And healthcare for primary care just shouldn't be that expensive. I mean, it's about $125 a month is my monthly membership fee. That could be 5 visits, 0 visits, 1 visit.
That's crazy good. Good job by you.
Thank you. Yes, 125 people just pay month to month. I have no interest in doing long-term contracts or roping people in, although they just do an initial 3-month because I cannot fix all the problems people create for themselves within like 1 month. So 3-month minimum, but after that, there's no long-term contracts. So I'm just very interested in, like if I'm not working well for the patient, then they should leave and find something else. And they should choose me because I'm good at what I do and because they want to see me. And that's good. And there's, it goes actually down from there. 125 is the highest. And then as you add family members, it's less. And there's family plans and most direct care patients are like that. People use HSA money, FSA money for it. There are no additional fees after that. There's not a copay when you show up. There's not a bill after the fact. There is no additional billing. I don't want to have to create bills and collect that crap. I'm just once a month. People pay me. It's again a membership plan, like your gym. You pay for VASA. If you don't go, that's on you. That's fine. But you could also go 30 times and then there would be no added fee. Does that make sense? So it's like a membership model like that. And then another way that direct primary care doctors are saving patients a lot of money is by directly contracting with other vendors to provide very inexpensive things like tests and labs. So like, for example, I have a client bill account with LabCorp and all of my labs are essentially like $5 to $8 each. So patients can come see me because again, they're not that high price. They're just marked up for insurance. It's all a big scam and there's so much middlemen making so much money. So like if people want to have cash pay, I'll just be like, well, you can get an MRI for $399 here, or you can go through insurance, which will probably cost you your whole deductible. I don't even know, more than $399. Or for example, labs, like same thing. So they can get like a full set of like yearly labs for around $35 cash, no second surprise bills later, or they can bill it through their insurance. Again, I don't care. But I really can't tell them how much that will cost. And that's the problem with the whole thing, right? Because we're taking away people's autonomy from their own healthcare dollars and they're just pawns in the system. And I'm not okay with it. So I'm trying this new model. So if you know anyone that might work for, I'm in West Jordan and I do adults and children. And then I cover 3 hospitals for like members. I don't know, questions about any of that or anything?
So you were the Copper Beyond 98 to Binghamton?
Yeah, I was the owner of that for,
Yeah.
sold.
You may have seen my kids. We've been going there and we're sick of that place. That's awesome.
No comment.
Yes.
We're just a number, yeah, it sucks.
I will, in defense of them, say it is so much the system.
Gotcha.
Yeah. There are good people trying to do the right thing and they're getting beat out of them.
Trying to get an appointment's a joke.
Yeah.
We actually have a friend who works in the office there, Misty.
Yeah.
She gives us appointments because we call her. Can you hook us up?
Yeah, she's one of my besties. Yeah, people will complain all the time with good reason, and it's true, it sucks. I mean, that's why people are like, oh, why wouldn't I just pay this? And like, I have like access to an actual doctor who knows me, who can see me anytime I need, who's going to answer my 12 doctor hours, like be there for you, versus the other. And the sad thing is that it's just, we're all programmed with this insurance system, so it takes people to take a break and get out. But it's a very tough business running a primary care clinic, I will tell you that.
Thank you.
Okay, so let me know, reach out if you have any questions about that, or you know other doctors that are interested in the model or trying to find out, or just anything. Thanks, you guys.
So actually, a quick
Oh, yeah.
Is it only doctors on your staff or do you have PAs?
So right now it's just me. Because I asked everyone I know and they were like, that's so awesome. Okay, you do that and I'll watch. I'll just be over here with my paycheck. I was like, damn, I understand. So it's just me and I have one medical assistant. That's it. But yeah, no, they were all at Copperby. Yeah, I love them dearly. They were like, that? Wow, no. It's risky. It's risky. If anything new is risky, like running my own business, I won't lie, it's hard as hell. And I'm primary breadwinner for my whole family that I showed you, but it's also super fun. Like I'm going home every day just thinking like I kicked ass and I did all these, like I really did awesome work for them, like what I want to do. So
I practice medicine instead of just insurance says I have to do these.
Yeah, I'm literally
Yes, and
a
everything.
slave. Yeah, to them. So, all right, cool. Thanks, you guys.
Thank you. This was a great example of what we do here. It's like we learned from, they learned from you, and you learned from them today.
It's true.
And so, our staff
Yeah.
comes in and educates you guys, that's why it's important for you guys to share your experience back. We appreciate that, we do that with our case reviews and everything else. So,
Yeah. How many
thanks.
people are online? Like,
we have about 18 online.
Oh,
We
it's
have
cool, but in
overall
person
that
is
come
fun.
and- Came and went, so, good job, thank you, and
My
appreciate
pleasure.
you, and thanks everybody else, thanks for those online too.
Thank you.
Oh.
thanks, you guys.
You also thought.
Are there any guys are interested that I can help?